what we're going to do today is a catheter ablation for atrial fibrillation, basically from start to finish. So I just want to tell patients this is basically, for the most part, a very easy procedure for somebody with experience to do, although it is something that requires a doctor who has done a number of these. I don't think you'd want to go to a doctor who does these sort of as a sideline. The way we do these ablations is we put little tubes in, they're sort of like IVs, that we put into the veins in the leg. The veins in the leg are very large. Could you lock the door there, please? Good. Let's start again. The way we do these procedures is we put little tubes in called sheets. These are put into the veins in the legs. We put a few of them in, and you can see that basically it's a very small little tube that goes into the vein in the leg. And from these sheets, we can actually put catheters. These are basically electrical wires through the tube and up into the heart of the patient. And then when we're in the heart, we can record electrical signals, we can do our mapping, and we can do our ablation and eliminate the abnormal tissues that cause atrial fibrillation. All right, so I'm going to start by putting the tubes in the leg of the patient, and I'm going to put the catheters in, and then we're going to do our map, our three-dimensional map, and then from there we're going to do our ablation. Today we're using a technology which I talked about in another segment called force sensing. And the way this technology works is it actually can measure the actual force that the catheter is pushing on the tissue. So unlike the old days, which were about a year ago, we now actually know whether we're actually floating on tissue or touching it. We know how hard we're touching it, and we know whether we're touching it enough or touching it too hard. So when we do the ablation, we will know if we actually have good contact with the tissue, and that's what you need to get a good ablation. We want to eliminate certain abnormal areas that are causing atrial fibrillation, and the problem until recently has been that you really didn't know if you really had good contact and how hard the contact was, and you need that. If you don't have that, patients can have a recurrence because you've only stunned the areas, and then the atrial fibrillation comes back. Okay, so you ready?
Yeah.
Let's get started. By the way, this is Steve Eglinton, one of our fantastic nurses here. We have Jay over there. We have Michelle over there. We have our anesthetist in the back. We have an entire crew of people dedicated to doing this case from start to finish safely and effectively. And that's, by the way, the other thing that you need if you see a doctor and you have an ablation. You want to not just have the doctor, you want to have the facility. You want to have the mapping equipment. You want to have all the safety precautions that we typically take that are in place. You want to be in a place that has open heart surgery, although we have never, in my career, ever needed to use it. We want to have that in case there is some type of complication. You want to be ready for it. And really, the other thing we need is we need a crew of people who are technically experienced, who know the equipment I need, who know how the procedure is done, because it's not just me. It's all the other people here, including the gentleman behind us, who you'll see in a second, Mike Driver, who works at Biosense Webster, who is going to help us with our mapping today. All right? So, ready to get started? Let's get started. So you can see it's very easy for me to put these tubes in the patient here. There's only a little needle stick. It takes me about a minute to put each side, put the tubes in, and we'll typically use both groins in the patient. It's just easier on the patient if they have the catheters in both sides rather than one side. Thank you. Okay, so Steve, you can just hold a little pressure here for a second, please. Thank you. And we're going to put another 2 tubes in the left side. Now, physicians will sometimes put a number of different catheters in, and it depends on who you go to and their experience and their comfort level, but they'll sometimes put in ultrasound catheters and other types of mapping catheters. Our philosophy is we'll use those if we need to, but we try and minimize the trauma to the patient. So for most of the cases I do, I'll usually just put in 4 sheets, okay, for our mapping and reference catheters and for our ablation catheter. All right, so I'm going to put another 2 in on the left side now. really very easy to put these things in. It only takes about a second. So this is basically the extent of the trauma that the patient has, which is, you know, at least for their groin, is 4 needle sticks. The nice thing about this is also these are in the vein. They typically heal very well without a score and with only a little bit of a bruise, which goes away in 2 to 4 weeks after the ablation procedure. You can let go, Steve, that's fine. And these are such small tubes, you sometimes have to wiggle them a little bit to get them into the skin. Anyway, they're in. And so now we have completed, basically, the surgical portion of this ablation procedure. There's going to be no additional punctures or cutting or anything to this patient. We're done with that. Everything else is going to be in putting catheters in and actually finding the areas in the heart where the abnormal rhythm's coming from and fixing those abnormal areas. So we do need to use a little bit of X-ray, but not a lot, to put our catheters in. So could we lower the lights, please? Lower the lights there, please. Michelle? It's Michelle Rogers, our excellent electrophysiology nurse. And Michelle, could you move the monitors a little closer to me, please? So here's our, this is one of our catheters. It's a quadrupolar catheter. This is going to go into the right atria. And you're going to see, I'm going to X-ray in a second. You'll see on the X-ray, particular patient has a pacemaker defibrillator.
You okay with the NG?
The NG is good. What Jay is doing is she's actually putting some X-ray dye into the esophagus of this particular patient to make sure that we are careful with the esophagus, which is one of the structures we want to be careful about when we do an ablation. So if you look at the X-ray, you'll see this. That's good, Jay. You can pull it out. Just putting some X-ray dye in. It's a safety precaution, and really safety is number one to us. We want to try and be as safe as possible when we do these ablations. I'm going to put another reference catheter into the heart. Now this is a 10 electrode catheter, but you can see how small this catheter is. It's sort of, it's sort of like a thick hair, the size of it. So this is, you know, minimally traumatic for most patients having these things in. They just have, you know, 4 tiny little holes in the veins of the leg with basically big IVs. And when you pull them out, you know, patients can usually go home. For many patients, we can send them home the same day even, and they can go back to work the next. But since we're using a general anesthesia, we usually keep people overnight just to be on the safe side in case they have any side effects from the anesthetic or from the ablation or anything else, although typically that's not an issue for most of our patients. Okay, very good. So that is in the coronary sinus, this catheter, which is one of the veins in the heart. And now we are ready to go over to the left side of the heart, which is where atrial fibrillation comes from.